Good afternoon, everybody, respected chairpersons. It's always a pleasure to be invited to BTCon, and I think it's for many years that I'm coming here. But this year, it's a pleasure, a special honor and privilege to be awarded the PDF guest lecture on type 1 diabetes. And I thank once again Dr. Vishwash for this honor. I will be dealing with actually my topic, as you can see, has two topics merged into one. One is the clinical challenges on which I devote a great time and researchers' realms. So, what's the frustration of type 1 diabetes? Type 1 diabetes, those who are dealing with such patients, is a serious, lifelong, chronic metabolic disease, and also say debilitating disease. It is extremely brittle in its metabolic healing. Complications are early and debilitating despite reasonable treatment, and this decreases the life expectancy despite the best of treatments. Management is resource intensive. It requires not only money but time, education, understanding, involvement, and continuous dedication, not only by the patient, but his or her family members. And this calls for understanding, cooperation, and empathy of people coming in contact with an index person with type 1 diabetes. This is true all over the world. To add to the problem in India suffers from the constraints of overpopulation and inequitable distribution of resources. And there's a low prevalence of type 1 diabetes in India, which is both an advantage and a disadvantage. A little bit of the staggering statistics, though India has one of the lowest prevalence of type 1 diabetes, especially as you compare with Scandinavia or North America. As my previous session's chairperson was pointing out, India as a country has the highest number of type 1 diabetes children. And I was alluding to the increased mortality in type 1 diabetes. This is from the recent IDEA Atlas. The life expectancy of a 10-year-old child diagnosed with type 1 diabetes is lower than the life expectancy of a child who doesn't suffer from diabetes. And even you compare between, say, North America and Europe, Australia, so compared to these countries, in India, the life expectancy is even lower, maybe to the tune of 30 to 44 years only. So what are the challenges in type 1 diabetes? The challenges are many, and you try to find out any field, there are challenges. And more importantly, the challenges are not exclusive, but are interdependent on each other. For the paucity of time, this afternoon, I will be concentrating only on the medical challenges. We all know what are the pillars of diabetes management irrespective of time. The four major pillars are diet, exercise, medications, and monitoring. To that, a fifth pillar has been added, that is diabetes self-management, education, and support, or DSMS short. Now, what are the challenges in nutrition? Proper dietary recall and dynamic customization of diet requires continued services of well-trained nutritionists. Those who are practicing in the urban areas can have access to nutritionists, but in mind that India is a vast country with a large number of rural and semi-urban populations too. There, the resources of a nutritionist may be lacking. And nutrition counseling or nutrition advice in diabetes is typically for most of our patients is a one-time affair at the first visit or the second visit. But this should be a continuous dynamic process, which I think very few patients can avail of. Then there's lack of use of carbohydrate counting among our patients of type 1 diabetes who sometimes do need it. We need to dispel a lot of myths about diet. There are daily variations in diet which will reflect in glycemic variability, itself a very frustrating thing in type 1 diabetes. And addressing nutritional requirements at various phases of life, childhood, adolescence, old age, need be considered. And puberty and adolescence is the very crucial phase of life of a young type 1 diabetic patient, because in this age group, many food fatisms come, rebellion comes against the treatment prescribed, and the gonadal steroids tend to make the metabolic milieu even more brutal. Addressing nutritional requirements during sick days and in diabetes with comorbidities is also a challenge. Defensive snacking owing to hypoglycemia or owing to the fear of hypoglycemia leads to hyperglycemia and weight gain, and that can again add to the insulin resistance and worsen glycemic control. And these individuals often suffer from psychiatric comorbidities like anxiety, depression, diabetes distress, and eating disorders like anorexia nervosa, bulimia nervosa, which also precludes proper compliance to medical nutrition therapy. Coming to exercise and physical activity, facilities for advising and supervising structured exercise by trained professionals are virtually non-existent even in urban centers. These days, we consult a physiatrist or a physiotherapist only if the patients have neurological or orthopedic morbidities. But referring a patient for a good, rational, acceptable exercise program to a physiatrist or a physical trainer just for diabetes and no other comorbidities is a concept unheard of in India, but is a concept which needs to be developed. Second, extreme lack of infrastructure, time for safe and effective exercise. I would request all of you to keep your mobiles either in the silent mode or switched off, otherwise this causes distraction and repeated phone calls come. So there's lack of infrastructure and time for safe and effective exercise. In the Nordic countries, in Switzerland, the working hours are around 6 to 8 hours a day. And in India, we work for 12 hours a day, including doctors, and we talked about it that we work half of the day. But in doing so, we do not get time for exercise. Inability or unwillingness to spend on exercise programs. Many people, even if they have the money, would like to spend it for exercise gears, good footwear, good exercise dresses, or machines, or even going to the gymnasium. There's absence of exercise customization in view of comorbidities. The only exercise that is advised to our patients are diabetes that beyond walking, there may be other alternatives like weight training, arm ergometry, calisthenics, yoga, which also can have equal benefits, is never discussed or talked with our patients. Nutritionists sometimes talk of food exchange things, but who talks about exercise exchanges in these patients? And therefore, this exercise oblivious or ignorant to the usual cautions. As for example, taking a heavy exercise just after taking insulin or taking exercise in empty stomach. Now comes to the main problem, insulin. Insulin is the mainstay of treatment of type 1 diabetes. There is limited availability of insulin. Yes, there is. You cannot think of India just as Kolkata or Durgapur or any other metropolitan city. A type 1 diabetes, for hailing from a rural area, we have to travel 100 kilometers to go to a shop which stores, keeps and sells insulin. So availability is a problem. Issues with affordability. Insulin is, even the human insulin is costly to many patients. And insulin alone will not do. You have to pay also for the insulin paraphernalia and also for monitoring. Limited availability of insulin free of cost to those who really need it. Of course, from government hospitals, insulin is being supplied for free, but the supply may not always be seamless. Issues with proper storage and transport in a predominantly hot country. We know, we have read in the books that insulin is stable at room temperature for 28 days. But what does that room temperature mean? In Western literature, it means around 25 degrees Celsius. And in a country like India, now we are having 45 plus degrees Celsius temperature for a considerable period of time. Can the insulin be kept out of the refrigerator in that temperature without loss of potency? Nobody has the answer. Then the question of glycemic variability, which is inherent to a disease called type 1 diabetes. Hypoglycemia leads to poor quality of life, or hyperglycemic surges lead to oxidative stress and can contribute to chronic complications. However, it's a less with newer, short-acting and long-acting analogs of the insulin pump. Then comes the insulin delivery devices. Challenges are there also. Subcutaneous injections are the best time-tested and most widely used method for delivering insulin. As I have mentioned, insulin injection paraphernalia adds to the cost of chronic therapy. One needle costs around 11-12 rupees. We do not count that, and this cost is generally not reimbursed. Even in government hospitals, the human insulins are provided for free, but not the needles and the syringes. Reuse of needles makes injections painful and sometimes can contribute to lipohypertrophy and inaccurate dosing. There is a great need for self-injection. For that, the trained healthcare provider has to spend time with the patients, which is often not available to them. Indian patients resent injectables because of trypanophobia that also needs to be addressed. Pain injectors have become a much patient-friendly way for delivering injections. But the order of the need of the hour is the smart pens. These smart pens have not been launched in India by any of the multinational companies like Novo Nordisk or Eli Lilly or Sanofi. They fear that will increase the cost of device and cost of therapy and would not be acceptable to the Indian patients. Like this Novopen 6, someone once can buy online from the United States, but a thing that is not available in India if there is any problem to the troubleshooting. Now, alternative to subcutaneous injections, insulin pump. Yes, ideally all Indian type 1 patients should utilize the convenience of pumps, but the cost, lack of motivation, and lack of support services precludes its widespread use. I think about 10% of our patients of type 1 diabetes can really afford the pump. They have the motivation to use them. But if you are afraid of prescribing the pump to them because support services and special educators are often absent to do any troubleshooting. Only the treating physician cannot do all this. Other alternative routes are only experimental and cumbersome than to with the dubious efficacy. Next comes to monitoring. Monitoring of type 1 diabetes includes home self-monitoring, clinical monitoring by the physicians and paramedics as many other illnesses, and periodic laboratory investigations. For home blood glucose monitoring, we have to fall back on CBG or AGP, that is ambulatory glucose monitoring. Again, the question of affordability, availability, motivation to undertake meaningful structured monitoring, and acting on the data generated in conjunction with the HCP arise, and there are inaccuracies and inherent variability both in the CGM and AGP devices. The common AGP device that we use, Abbott's Libre or Libre Pro, I think still suffers from the malady of detecting hypoglycemia too more sensitively, unnecessarily alarming the patients. And this frustrating glycemic variability in type 1 diabetes, this has many factors. Apart from patient-related factors, patient being compliant or not, it depends upon the type of exercise the patient is doing, the inherent glycemic variability of the insulin, fortunately less with the modern design ones, inherent variability in glucose testing, then methods of food preparation, quality of food, quantity of food, role of local inflammation, site of injections, insulin pharmacodynamics, and all these factors lead to tremendous glycemic variability in type 1 diabetes, which tends to demotivate the patient. The last part in this is the diabetes self-management education and support is a must in type 1 diabetes management. Again, it is very restricted in availability and accessibility. Even in some centers impart initial education, continuous and emergency support services are often lacking. The paid services, even if made available, will have poor acceptability among those who can afford the same. So, there could be some patients who can afford it, but if I tell that patient or parents that you come to me every month or every 3 months, go and meet my nutritionist every month or every 3 months, the diabetes educator and the podiatrist, and maybe also the psychiatric counselor, the patient, even if the patient or the parents have the money, they would simply say, no, doctor, I'll come to you, I will not go to the paramedics over and over again, but that is what is needed. And psychological aspects are often overlooked. So, these are in summary, these are the problems, these are the challenges in managing type 1 diabetes. Now, I've been asked to deal with the challenges, but if I do not give you some answers, some solutions, it will be unfair. So, we have to, as clinicians, we have to search those solutions. First, improvisations in resource-constrained situations. For example, if you do not have a trained diabetes educator or a diabetes specialist class, you can train your clinic assistant in imparting in the patient's insulin administration education. So you can train your clinic assistant. Suppose you are having a diabetes educator, you train them to double as a nutritionist. Suppose you have a dietitian, you can train him or her to double as a diabetes educator. And setting up of more dedicated diabetes clinics and type 1 diabetes clinics. What I advise my juniors who have an interest in diabetology but doing general practice or family practice, I tell them, you earmark one day of the week when you would exclusively see patients with diabetes and educate them. Maybe one day, say Friday, you do not see any other patients, any other chronic patients. You see only all your diabetes patients, and so that you can give more time for individual as well as group sessions. Integrated diabetes care that should include MNT, that is medical nutrition therapy, PMR services, biochemistry, neurology, ophthalmology, nephrology, cardiology, podiatry, orthotics, and various other allied services under one roof can be organized only by the referral government hospitals or big corporates. On an individual basis, this is supremely difficult to arrange. Training and engaging services of the appropriate paramedics. We are now having a lot of diabetes educators passing out every year from various institutions, but they are being underutilized. And taking the help of artificial intelligence, AI will come in a big way in medicine and diabetology, particularly, and initiatives at individual, government, and corporate levels. Yes, something has been done. This is the National Health Mission has earmarked some money for management of type 1 diabetes, and taking help of that, our dear dynamic colleague, Professor Shujoy Ghosh from IPGMER, has developed the integrated care for type 1 diabetes, the West Bengal model, and I'm proud of it. And this includes running type 1 diabetes clinic once a week in the peripheral hospitals, district hospitals, which is attached to one medical college, and services are given. And for example, Dr. Shomi Koshani of NRS Medical College, my colleague, has adopted the Imambara Shodol Hospital in Hooghly district. He went there on a couple of occasions. Now they have telephonic contacts. So this includes structured diabetes education on self-management and self-monitoring, insulin doses adjustment, sick day rules, nutrition and exercise. And there is a component of telemedicine included into it. And in case of emergency or seriousness, these patients can be referred to areas like the Department of Endocrinology in the hospital where I am working in, not any other such hospitals. So these are about the challenges, a little bit about the research in the field of type 1 diabetes. Type 1 diabetes being an incurable, difficult to manage disease with the potential of widespread complications, having increased morbidity, mortality, and tremendous social implications. Research should go in targeting every aspect of the disease. Those who are research-minded only will have to find out an area which interests you and you invest your energies into that area of research. Research may be there to prevent type 1 diabetes, to cure type 1 diabetes altogether, to improve existing treatment modalities, to devise injection-free treatments, including injection-free insulin, easier and more accurate diagnostic modalities, prevention of complications, and elimination of treatment-related adverse effects, notably hypoglycemia and weight gain. So one of the examples is tear glucose. Now we use the blood with the capillary blood, the venous blood, the interstitial fluid for assaying glucose. Another alternate is the tear glucose. Then translate food images into nutrient information using artificial intelligence. What the patient does has an app and puts the camera of the phone in front of the food plate. The app converts the image and translates it to how much calories that particular food plate can contain the food contains. That's the way of carbohydrate counting with the help of AI. But it has been seen that the larger the size of the meal, there is greater discrepancy between the calorie counted by the app as counted by a trained nutritionist. Next, of course, we are awaiting the availability of one disappoint them. I tell them, no, you have to keep on taking the short-acting shots, 3 or 4 shots a day. Only when it comes to the basal insulin, you can do it once weekly instead of the standard daily glargine and degludec. However, this all-6-glycodate in type 1 diabetes patients didn't find much interesting results. So it is not much encouraging for type 1 patients. Similarly, with Afrezza, the inhaled insulin, it appears very cumbersome to me, the dose adjustment. There would be issues about bioavailability, but still I think this would be an option to the offer to the patients who would not like to take multiple daily injections of some kind, injections of insulin. But again, they ask the question, doctor, when Afrezza will come, we don't have to take injections at all. That is wrong. For the basal insulin, you have to take injections, or this is only for the prandial insulins. Then the smart insulin patch, sort of trying to closing the loop, is being tried. That's also in the realm of research. Monitoring of complications, again, artificial intelligence can be taken help of in screening for diabetic retinopathy. This has many countries like Australia are using it, so this is a smart thing. And the similar thing can be done for categorizing foot ulcer by the foot scan app. So the patient or the healthcare worker takes a photo of the app, and the app converts it to how much serious it is, what is the classification of the foot ulcer. Even in our department, we are running such a study. Then, of course, immunotherapy of type 1 diabetes, Diagnose, this is an anti-CD3 monoclonal antibody, is approved for prevention of type 1 diabetes in stages 1 and 2, and it may delay the onset of diabetes by around 13 months only. And other monoclonal antibodies, including rituximab, are in trial, and so also anti-glucagon receptor antibody. Coming to transplantation, pancreas transplantation didn't appear much interesting, much encouraging, but the results were better with islet cell transplantation, and now efforts are on to develop a bionic pancreas that is closing the loop, that is connected to a sensor, but these are prohibitively costly also. And cell therapy, that is Donnie's cell, has been approved in 2023 by US FDA for the management of brittle type 1 diabetes. This is just to show you a few glimpses of the possibilities of research in the field of diabetes. And I end with this paper which came out from our department, which was done by one of my residents, Dr. Prashant Gaikwad, who tried to look at the relationship between ambient glucose and glycated hemoglobin, and it has been found that as compared to the Westerners, our patients have a lower glycated hemoglobin for a given glucose. So to conclude, therefore, type 1 diabetes is really a challenging and at times a frustrating disease to deal with, especially when these are young children. And this is a lifelong disease with a burden of complications, so much so that in 1989, in front of Banting House at London, Ontario, Queen Elizabeth II ignited this flame of hope in front of 4,000 odd audience to honor Sir Frederick Banting's discovery of insulin. And this flame of hope also serves as a reminder that insulin only manages but does not cure